This conference will now be recorded.
And welcome to the low and intermediate prostate cancer session with AnCan. And I wanted to mention in the chat window, I've posted information about the Solo Arts Heal coming up this Wednesday at 7:30 Pacific time. And a young woman, Kelly Spillman, who is a stand-up comedian, and before getting a visit from cancer, she toured the country um, as a stand-up comedian, and now her routine addresses the issue of that. She's a psychology professor, a storyteller, and a stand-up comedian. So I think that'll be a good session if you can make it and join in. The link is there, and you can either watch on Zoom or YouTube once you click through on the link. Mark, wanted to check with you to see if you needed any time tonight.
No, I'm good. Thanks.
Okay,
Nope,
so
nothing.
we can start with Jim Stewart. We'll let you go ahead and update us.
All right. Well, hello, everybody. I just want to give everybody a quick update since this group's been so helpful to me. I had my 3-month follow-up visit with the surgeon after my prostatectomy, and my PSA level was 0.038. And he said he would have liked to seen it a little bit lower, but he said given my pathology, he wasn't concerned at all. And so I'm on a monthly PSA regimen right now, but he wasn't terribly concerned, and said there's no reason to start any treatment at this point in time. So I consider all of that good news. I don't know if anyone's had any similar results from their surgeries, but anyway, that's really all I have to say, and that's my update at this point.
Great. Has anybody else followed PSAs after surgery and had concerns or issues about that? Mark?
Yeah, I had radiation last year. I've had three tests, and they've both been 0.08. I have another appointment coming up, so we're waiting to see. I like to do them every 3 months, but I think we'll go to 6 here in a little bit.
I'm sorry, your audio broke up right at the point what, 08? Wait, you're unmute again. You're muted, Mark.
Okay, at 0.008 3 times. So that's what I got right now.
And how soon is
Can
that
you hear me?
after? Yeah, we can. How soon was that after radiation?
3 months. It's been a year and a half now since I had radiation. So it's still at 0.008. So we're happy campers.
Yeah. That's not 0.8, it's 0.008. That's really good. At 3 months,
Yep.
That's almost unheard of, that kind of response.
That would be
That was
undetectable
radiation.
almost
That was
every other
radiation,
guy.
not surgery.
Yeah, after radiation, that's a real quick drop, so that'd be good. Anybody else have any comments for Jim? Okay, moving on.
Let's just make sure that he's on a safe track. I guess I'm missing a little something. So, you didn't have any metastasis, and you didn't have a very, very high Gleason score. Are there any high risk factors that we should worry about? Although you're going to have PSAs every month, so there's not much to worry about. But I just want to know.
My Gleason score was 7. The pathology was all contained in the gland, but I've got the BRCA2 variant, so
I
that makes them
see.
a little more cautious. Maybe that's why I'm on a monthly PSA program, but I have so much confidence in my surgeon that even though it's a little higher than he would like to have seen,
Oh,
I'm okay with this program, and unless I learn something different. But
okay, thank you. I just wanted to catch up and make sure I got the big picture
yeah,
before
and
we let you go.
I didn't have the surgery in Reno. I went to UCSF to have the surgery done. So it's that's that's kind of an important detail. But
Rick,
No,
you've mentioned in the past about a BRCA group that many of the people have gone to. I wonder if you can share that information.
well, we basically created a BRCA Brothers email list, which connects all of the gents who carry a BRCA mutation, and a couple of non-gents, because Dr. Pamela's on that, is also on that list because she has the BRCA mutation, and I'm not sure who else. And it's great because the guys can communicate between themselves, and they're all very supportive of each other, and we're really, really happy to make that connection. And so that's all it is. It's just an email group, Dr. Mark. I have a question. What about the rest of the other guys who have had surgery in here, like Jim and Jim Schreight and Dr. John and Boykin and Causley? Where were your PSAs within a short period afterwards? I mean, did you? I know Causley certainly hasn't had to deal with recurrence. Thank God, he's had other
Praise the
issues, but
Lord.
not
Yes.
recurrence.
No.
And Jim hasn't had to deal with recurrence. So can either of you give Jim Stewart a sort of a reference as to where you were after surgery?
I'll speak to that for myself. Right after surgery, I was a point 1.10 after surgery. But I'm 2 years out from surgery right now, and I'm undetectable.
Oh,
It's
wow.
less than 0.001 or something like that.
Okay.
So they're saying that's undetectable. So, within 2 years, I went straight to undetectable, which is a good place to be.
Yes. Yes.
I was afraid somebody was going to ask me that, but it's been 14 years and I really can't remember. Whatever it was, 6 months after surgery, it met Northwestern's criteria for undetectable. So, and thankfully has been that way ever since.
In my case, I was something like 0.06 6 weeks after surgery and 0.18 12 weeks after surgery. So with that trajectory, a Gleason 9 and metastatic, I was treated pretty aggressively for those days.
It's interesting that with metastatic disease, that it would drop that low and then go up again, as opposed to not reaching a nadir.
Mm-hmm.
It means it was fairly active metastatic disease, I would guess.
Yeah, they got one metastatic lymph node out, but there must have been more of them sitting there. This was before PET scans were available.
Those are the dark ages, huh?
Those were back in the dark ages. They put some leeches on me, and then I was undetectable after that.
Paul, you are just signing in. are you going to need some time this evening? You need to unmute yourself there.
Hello. I'm just monitoring right now, listening to you all, what you got to say. I've just been diagnosed with prostate cancer, so I'm kind of getting trying to get as much information as I can. So
Well, it
sounds
may
like,
be very helpful as a new visitor to share your story. And we've got people who've been through all kinds of background uh, and can give you some input, and questions to ask, and things to consider as you journey forth. So if you want, we can hit someone else up first and then come
okay,
back to you. But
okay.
we'll be glad to hear your story and then make some comments on that.
It's a very
Um,
short story.
well, then go ahead. Tell us.
Well, I've only been diagnosed, and a lot of it I don't understand. So I'm really at the beginning stage, and I'm getting ready to get a second opinion. So I'm really at grassroots right now.
Well, let's start with how old are you, Paul?
I'm 71.
And where do you live?
I'm in Georgia,
So was
North
I.
Georgia. Oh, yeah,
So
okay.
was I. And I ended up traveling to UCLA because I just was not happy with the options that were offered in Georgia, in Atlanta, at Emory, and Piedmont, and some of the other places as well. Things may have changed a bit since that time, but what got you to the doc that they made a diagnosis?
My PSA was going up, and I think what alerted it, it went from, I don't have my notes in front of me, and but it went from like 3.5, and then it went up to 4.6, and now my recent one was 5.6, 5.6. So this is, I mean, I've had that, but, I just recently had the PET scan and MRI to confirm that I do have a problem. So, but I had really very difficult, had a difficult time getting explanations on we've done the GPS report, we've done a decipher report. In both cases, I'm considered intermediate. How do they classify it? I don't know if the numbers mean anything to you, but a GPS is 31, which is just over. It's moderate likelihood, I guess.
Mhm.
And
Let
on
me.
my decipher,
Mhm.
okay, go ahead. Yeah, I don't know where
No,
to
go ahead
start,
on the
so
decipher.
I
Go
got
ahead on the
late coming in
decipher.
here. Okay, my decipher was 0.46, which is intermediate risk. But in there, they made a note that this patient may not be ideal candidate for active surveillance, and that's a route that I've been wanting to go, is active surveillance. And
So when they did your biopsy, had you had the MRI before the biopsy to provide the targeting for the biopsy?
yes,
And how many lesions? And do you recall the PIRAD scores?
that's where I would have to look here and see what I've got. I just saw this coming up, and I figured I'm gonna jump on board and see if I can learn something. I have a lesion on the left anterior. It's RAD4,
Okay.
and also another area that's RAD3.
And what did the biopsies show? How many cores and what kind of scoring on that?
With That's the part I don't really understand.
Okay.
Um, and I don't even know where to start.
You have the
Um,
report.
yes.
You could mention like how many cores they took, how many needles they used, and then how many of them were positive. So the things we'll look at or want to know, or your docs will want to know, is what percentage of the cores were positive and how much for a disease there was in there. They'll also look at things like perineural invasion, cribriform patterns, and whether they feel that the biopsy shows that it's near the capsule of the prostate.
Um, from what I can gather, and it looks like on the left lad, it was a Gleason score of 3+3, involving 1%. One of two cores contained cancer,
Mhm.
and the cancer length was 0.02 centimeters at grade group 1.
Mhm.
And then the index lesion was a 3+4, involving 16% of the specimen. 4 or 5 cores contained cancer. Gleason pattern 4 comprises of 10% of the cancer. Cancer length was 0.8 centimeters, grade group 2.
So I think that it's important that you find a physician who is experienced in the active surveillance to learn more. There was a great webinar on Saturday morning that Howard Walensky organized where the discussion was on active surveillance, and that should be available. I don't know if we'll ultimately have a link in our newsletter to help people get there, but AnCan also has a session on active surveillance with a group of people who are going through that, and that might be something to look at. Um,
I, I actually thought that that's what this was. I just came across it today. I mean, it was like a couple hours ago. I just came across it from the the group site. I think it was Zero. It's that pretty much where everybody is from, or the
well,
forum.
we're involved with the group AnCan that you can
And,
see. Rick was one of the founders of the group there,
okay.
and he's got his nice logo in there. So this is a seminar put together by AnCan, and they have a number of different sessions that are out there. There is an active surveillance group. There's low intermediate. There's high risk. There's a veterans group. Um, and men speaking freely, talking about other issues other than the specific cancer treatment. So this group is usually people who have decided to go through definitive treatment. Um, John, are you running the active surveillance, or is that James?
It's not
I
me. I'm in
okay.
high risk. The guy
Oh,
that you mentioned,
Jim,
Howard is in active surveillance, right, Rick?
Yeah.
Jim,
I,
Jim,
I,
come
Oh,
on
I
in,
Jim.
Jim.
yeah, I co-moderate the active surveillance group, and Paul, you don't have long to wait because we meet on Wednesday night, the first 4 Wednesdays of every month. So we'll be meeting about 48 hours,
Oh,
same
wow.
time, same place, and we'd like very much to have you join us. Uh, Active surveillance and kind of analyzing your situation is sort of our specialty. We've got guys that have been on active surveillance for a long time, and guys with different really stages of Gleason scores and that sort of thing, and they can share their experience with you.
One of
with
the
that.
things, one of the things that's very important, Paul, where did you get your biopsy done?
It was here in Georgia at Brazelton. I don't know if you're
Okay.
familiar.
And yeah, I'm very familiar with the area. Um, the pathology, do you know if it was read by the hospital or did they send it out?
Um, they sent it out to John Hopkins for
Fantastic.
review,
Okay.
Yeah.
and
Okay.
they
And
they
it's
they agreed.
okay. That's important because up to 30% of the time when it's done at a community hospital, we'll find that when Dr. Ming Zhao, who's at soon to be at NYU or Mount Sinai in New York, and Johns Hopkins, the readings will change. And it can either be for the better or it might be more aggressive. But in this case, I certainly wouldn't let them, I wouldn't have them push you to do surgery. You have plenty of time to get opinions on this. And I think if you attend that group on Wednesday evening, um, it'll be real helpful to load yourself with the questions you need to ask in making
Yeah,
that.
yeah. I'm actually seeing a urologist, and I've gotten a referral to go see a oncologist, radiation oncologist. So that is, I think, next week. So
Yep.
I think I'll get a better understanding because I'm not saying that he pushed surgery, but yeah, I know that's what they do. And I
And
was adamant.
well, in radiation oncology in Atlanta, main choices are CyberKnife at Piedmont Hospital, and that's a fairly good um, system if the software is updated. There's a Dr. Patel at Northside who is doing MRI LINAC, which I believe is state of the art radiation, but he hasn't been in the business of doing this for quite some time. And then there are places in New York, in Tampa at Moffitt, and out here at UCLA or UCSF. There are a lot of different experienced places, um, but I
You're
felt
not,
like Emory was
yeah,
pushing for doing 45 sessions of proton, and that doesn't seem to be necessary at this state of the situation. There's soon, either later this month or next month, a paper that's going to be published called the COMPARE trial, which takes standard IMRT and compares proton with photon. You'll see a lot of stuff about, gee, you got to do proton because it's safer. And I think that study is going to show that there's no difference between the proton therapy
that's what I've
and the,
heard. Yeah.
yeah. And if you can do SBRT in 5 sessions and you have someone who's experienced in doing that, you want to find someone who's working specifically in GU cancers, not someone who in the morning is going to do breast, in the afternoon brain, and then in late afternoon do prostate. So it may mean going to a NCCN center to get the best opinions on this.
Okay.
Do you know anybody in the Southeast who is very experienced in active surveillance, James?
I do not.
Yeah, no one mentioned that to me, but with good reason. I had a Gleason 4+3 and disease outside the gland when I was going through. Anybody else have some comments for Paul?
Rick has his hand up.
Yeah,
Okay.
yeah, I have a few things to say to Paul. First of all, I want to sort of settle you down because that biopsy result is relatively non-aggressive and easy to deal with, most likely. And it shouldn't. I mean, I realize that the word cancer in and of itself is pretty frightening, but it once you come to understand and all of the ins and outs, you'll appreciate that this is a very manageable situation on the surface, with 2 cores seen, 1 3+3, 1 3+4, and the longest core is 8 millimeters. So that's good, and you have a good reading confirmation that it's 3+4 from Hopkins. Now, I don't know, Paul, if you know how to use the chat window. That's the 2 little boxes next to in the top right, next to where it says 13. But if you
Okay.
click on that and you open it, there is some information in there for you. You don't have to copy it. If you just click on that link, it'll open up. You can read it later. But this is a study that I happened to see and circulate last week, and we'll probably feature it in the next low and intermediate. Dr. Mark has kindly summarized it, and
Tomorrow.
he's done most of the work. We just got to add a couple of little things, but it's interesting to you because it really looks at men in your situation and how many of them did active surveillance, were candidates for active surveillance, and it looked at them between 2010 and 2020. I forget where the database came from, but it was a pretty large base that they looked. Mark may remember. The bottom line is that there were 13.5% of men with disease like yours, 3+4, demographics like yours, at that time, who did choose active surveillance between 2010 and 2020. Now, we know that number's gone up a lot since 2020, largely down to people like Jim Schrate and Howard Walensky, who have been actively campaigning for the urologists to push more people towards active surveillance. We think that number is probably around 20% right now, based on information from the University of Michigan music program. But a lot of guys are eligible. And the urologists, a lot of urologists, especially urologists in community practices, would not have you believe that. They'd have you believe that you need treatment, either radiation or surgery, and a lot of the urologists would tell you you need surgery. There is some question as to whether a man of 70 or older is a suitable candidate for surgery. They never used to be, but more and more with the robotic surgery, more and more people are opting for surgery at 70 or over. It depends on how good shape you are, but the surgery is significant because you're upside down, meaning your feet is higher than your head for several hours.
Mm-hmm.
So we like to guide people towards doctors who are urologists who are very empathetic to active surveillance. We know one that does come to mind is at Sylvester in Miami. There's probably somebody further north. There may be someone at Tampa. It's not really my area, so I don't keep up on it. But if you come to the group on Wednesday, certainly if Howard Walensky is there, he'll know who the best docs are. Or if not, maybe Jim Schrate, maybe could you email Howard and ask him if he's got any name in the Georgia, closer to Atlanta than the guy that we're using right now. And if you were to go north, there are people there too. If you were to go to Chicago, there are people there too. But what we'd like to do is get you for a second opinion, not just to any old second opinion urologist in a community practice, but to get you to somebody at a center of excellence where there's no financial conflict of interest, there's no motivation for them to do a procedure, whether they're a radiologist, a radiation oncologist, or a surgeon. So that's really what I wanted to say.
Okay. So Emory is not what we would consider a
Okay, so Emory, I think I'm going to have to defer that one to Dr. Mark. Emory is, and that is a center of excellence. It's not an NCCM, but it is an NCI institution. But we've never had great experience. Dr. Mark, you're a local and an MD, so I feel you should answer this one.
And a former staff member. And there's a bunch of other stuff that I really don't want to go in this kind of setting. But I wouldn't send a family member there for anything. You know, I've had a lot better experiences out here. One of the things I would mention to you, which is interesting and is unique about Atlanta, is you can hop on a 6:30 flight on Delta and be to LAX by about 10:30 in the morning and fly back later in the day, should you want to see one of the people out here. But more importantly, on September 8th and September 9th, there's the PCRI conference at the Westin Hotel outside of LAX. And one of the speakers is Lawrence Klotz. And Dr. Klotz is one of the proponents, experienced proponents and authors in the area of active surveillance. So I'd certainly feel that, that might be a very good experience. So usually about 150 people attend these conferences. So you'll meet other people and experts in every single area that you could imagine. So if you have the time and enjoy traveling or have frequent flyer miles, that's something to consider.
That's September 8th and 9th.
Can I just correct you on one thing there, Dr. Mark, which is in the last live conference that they had, and whenever it was pre-COVID, 2019, 2018, they were getting about 1,000 people in person to the conference.
Okay, they had a one-day one that was about 150. So
yeah, but in the old days, they were getting huge crowds, and it is worthwhile. At the same time, Paul, we realize some people don't have the resources, but we would really like to connect you to somebody who is going to be empathetic and understanding of your 3+4 in one spot and not rush you into treatment. Do we have any other 3+4 guys in the room today? Stuart, are you a 3+4 guy?
Yes, I am.
Could you, and just bearing in mind that Paul has a very little bit of 3+4, could you?
Yeah, I was 3+4 on biopsy, and we decided to treat just because of the BRCA. If it wasn't for the BRCA, I would have been entirely a different course, but because of the BRCA, we decided to treat. But the surgical pathology was 4+3, so yeah, so it was a little worse. But it was 3+4 on my needle biopsy.
Okay, and just to explain before we go to Stuart, what Jim Stewart means, but we have 2 Jims and 2 Stewarts here. This is a little complicated. But what Jim Stewart means, what Jim Stewart means by the surgical pathology is if they remove your prostate, they slice it up and they come up with a definitive Gleason score. And that definitive Gleason score for Jim Stewart was 4+3. But Stewart,
Yeah.
you go ahead.
Paul, I can relate to where you're at because I was diagnosed back in April at 3+4, and my focus after the original doctor recommending treatment, in my case, the recommendation was focal, not full surgery, was I went to a number of centers of excellence and met with a number of doctors. And in all cases, the first question that I focused on with them was their opinion on treat versus surveillance. And you know, there were arguments on both sides, and part of it, part of the counseling that I got from some of these doctors were, yes, could be a candidate for surveillance. Partially, it's going to come down to your comfort with the concept of being in active surveillance and sticking to the routine of monitoring to make sure that it's not going bad on you, and that some people like that and some people don't, and that it really, a lot of the comments that came back to me was it really has a lot to do with you personally in terms of what you're comfortable with, allowing for the fact that you could treat now, you could wait, and you could see, and things could go well, and you may never need to treat, or 2 or 3 years from now, you may need to treat.
Another interesting study that was out there through the past year is called the PROTECT study. And this was a European study looking at people with disease confined to the gland. And they either got active surveillance, surgery, or radiation. And at the end of the I think it was 10 years, they had no difference in overall survival between the different groups. So there's also no studies that I'm aware of that compare focal treatment with active surveillance. It was mentioned in the talk over the past weekend that focal may delay the time to do definitive treatment, but that's very different than saying overall survival is increased by doing focal rather than just monitoring with active surveillance. So I think being aggressive, as Rick said, with a disease that borders on what some people now are saying shouldn't be called cancer, at least the 3.3s, there's controversy about whether it's still even called cancer. Cosley.
Oh,
Thanks, Paul. Paul, I just wanted to contribute just a little bit to the concept of active surveillance. We discussed it quite a bit already, but I put my number in the chat to you, and so you can call me sometime if you have an opportunity and you'd like to talk. I'm mentioning this only because I was a candidate. I was in active surveillance for 5.5 years prior to making a determination to treat. So it's an option that's available to you. And one of the benefits of that is that it gives you the opportunity to ponder the various treatment protocols that are available, and you don't have to make a hasty decision as far as that is concerned. So, it's food for thought. But my number is in the chat to you. Give me a call if you'd like to discuss that any further
great.
when you have a chance.
I appreciate that. I can just tell you, I am definitely not interested in surgery, because I've seen or read too many nightmare stories on that, and just too many side effects. So I think my first choice or whatever would be proton therapy or SBRT. And my brother had prostate cancer. He was on active surveillance for 5 years, and then it got to the point where he had to do something, and he had proton therapy. I think he had maybe 30, 35 treatments. And at the time, that was when Emory had just started with their equipment, but they really didn't have any experience. So he ended up going to, I think, Knoxville. I think that's where they have another proton machine. And he stayed there for the course, coming home on the weekends. But he's, indications are he has no more cancer. His PSAs and everything are down low. I don't know exactly what they are, but he was on active surveillance for 5 years, and I think it's been 4 years since he's had his treatments. So he's doing well.
Paul,
But
anybody else in your family with prostate cancer?
no, no, because my father died at an early age with heart problems. So that and my grandfather and so forth, they had cancer, but it wasn't prostate.
It would still be reasonable to look at germline screening. Um, and Rick, I don't have the AnCan link on that, but it's a study called Prostate Cancer Promise. It's prostatecancerpromise.org. And we have a special arrangement with them that when our people go over there, they'll be sent a kit. They do a cheek swab, and they're checking for, I think it's 29 different mutations that potentially could affect various types of treatment, and it's free. So that's a wonderful thing. And with a brother who had prostate cancer, that's not a bad idea to get. A lot of docs will wait until you have a recurrence, but if you know about it ahead of time, it's good information to plan. The other thing about I agree wholeheartedly with what Causley said. About half the people never end up with treatment, and of those people who end up with treatment, if it's 5 years later, it's probably much improved treatment than perhaps what they would have gotten originally. So the treatment that we have available to you in 5 years will be a dramatic improvement over what they can offer today. At that point, there might be evidence that there really is a benefit from doing focal treatment, or proton could turn out to be better than photon. But there's a lot of things that information that's not available at present. I wanted to ask Tim if you need some time this evening.
I don't. I don't think so. I got joined in late. Thanks, Mark. But I am a 3+4.
Do you have any comments for Paul?
I got diagnosed in May, and I'm just taking it slow and talking to a lot of people, getting information, gathering information, trying to form a strategy. Had 3 pathology reviews of 1 biopsy, and I'm not rushing it, and improving my diet, and trying to do the best I can for now. I am leaning toward SBRT.
Yeah, that's
Sounds
kind
good.
of what I've been looking at either proton or photon. I don't really know I know the difference, but I don't know what there's a difference in success in either one or the other. And I've heard
There, there,
cyberknife
there
and all
isn't.
kind. Okay.
There isn't, and Emory is not doing proton SBRT. From what I've heard, I think the 5-session proton is just a Mayo protocol right now at one of the Mayo clinics. I don't know if they're doing that in Jacksonville, but at Emory, it's 45 treatments if you go with them. I haven't heard of any change in that.
Actually,
Gerald, I wanted to
I
go
did
on,
meet
Paul.
with them I did meet with them, and they did say they're doing. There was an option to do the SBRT, but I don't know if it was a proton or photon. Uh, didn't really go into it at the time. But I think they are. But thing is, I would like to go where there's some experience and longevity with what they're doing. And I've read a lot about. I think it's Gainesville in Florida. They have a good hospital there with cancer success with cancer.
No,
I'm not
no,
aware of that.
Oh,
no,
I'm in the Tampa area at Moffitt
Yeah.
Cancer Center.
okay.
Moffitt, and then
I'm not
also Dr. Rod Ellis, who's moving to Tampa in the near future, is also
So
quite experienced.
can I
Um,
just say, don't get ahead of yourself, Paul, because originally you told us you really hoped you could do active surveillance, and you
Right.
may be a very good candidate for active surveillance. So before you start running around looking for the best treatment and comparing proton to photon and should you and SBRT and all of the rest of it, I think I'd be focusing on whether you're a candidate for active surveillance and finding a urologist who is going to support you if you want to do active surveillance. And I think um, that's the number one. I also put a connection. I put a link to the PROMISE study. Again, that's in the chat window. I just want to say this is nothing special for AnCan. All it does is just tracks the number of people that we've referred to the PROMISE study, which is probably somewhere about 150, probably more than anybody else. And if you use that link, it just tracks back. We don't get anything for it. It's just helps them track how effective we've been for
Gotcha.
them.
Okay.
So and they use the color test, which has 32 the major inherited mutations, has 32 mutations. But I
Now, is that
think
through the PROMISE study?
that's the PROMISE study, yeah. And they'll send you a kit. If you click that link, you put in your information, they'll send you a kit through the mail, and you use the cheek swab, you send it back, and if they do find anything, they will schedule an appointment with the genetic counselor.
Okay. And where are they located? You may already said
That study is being sponsored by Johns Hopkins and by the University of Washington, Fred Hutch. So it is an academic study, and so they're not really located, but it's Seattle and Baltimore.
Okay. And I'm sorry, what was the test they do? It's a genetic.
That is to
Okay.
test if you are carrying an inherited mutation.
Okay. But I mean, what do they call it? Is it just not called the PROMISE study, is it? Or
yes, it
Well,
is.
they're doing what's called a germline or inherited
germline?
mutation test. Germline test or inherited germline mutation or inherited mutation test.
Okay. All right. I'll definitely check that
James,
out.
James, you had your hand up.
Yeah, first of all, I want to echo exactly what Rick said. I think he put it very well. You've got time to sort this out, and you have every reason on earth to do that, because treatment of any kind is really going to change your life, and not necessarily for the better. So take a deep breath, sort this out, and take your time. Because from what we're seeing here, I think you've got time to think this through and make a decision that you're really going to be happy living with. The other thing, just as kind of a housekeeping matter, if you haven't already, put your email address in the chat. We'll see that you get notices of the meetings and that
Okay.
sort of thing. And I really do hope you can join us on Wednesday night.
Oh,
What time is that, James? Is it going to conflict with the comedy, the solo arts? That's 7:30 Pacific time.
Okay. It's at 7 o'clock Central, which is 8 o'clock East Coast. Pacific.
That'd be 5 o'clock. So you're before.
Yeah, we're before.
Wow, so you can get both ends. You can get what you should know is, sit on it. You have at least 5 years, according to Causley, to make a decision versus the lady with stage 4, who's a comedian, and she's full-time dealing with her cancer when she isn't telling jokes. Daryl, are you new to work here? We can't hear you. You're on mute, but we can't hear you.
You may need to select the right microphone. I can see you're on the telephone there, and we can't hear you, Daryl.
No, unfortunately, still no.
That's my older brother, Daryl.
I think that one thing you could do, but I don't know if you can do it at the same time, is you can call in, and if you can get to the chat window, we'll put the number to call in. I'm not exactly sure why your microphone isn't picking up. The other possibility is to go out and come back in again, Daryl. Sometimes that works. But if you go out and come back in again, we'll have to post the number in for you a second time, because you won't see it.
Okay, so Richard, you had said that you would like time this evening.
Yes, thank you. I'm 90 days out from the SBRT treatment, and I just wanted to. Well, actually, I have two issues. This will be the first. 90 days out from the SBRT treatment. Right at the beginning, I was experiencing after the treatment discomfort, but I urinating, but I've got some alfusin prescribed by the oncologist, and that has helped. But now, 90 days out, I've noticed a increase in urgency and leakage by the time I get to the bathroom, and then the flow is slow, and the discomfort has increased. Now, being 90 days out, has anyone else after SBRT experienced anything like that, and have any feedback?
Greg?
I never had SBRT. I did have seeds, and I did have additional radiation. But what can happen is that there can be inflammation there, and the inflammation over time can cause this urgency and quite possibly the other side effects. I would defer to Dr. Mark, because he's so good on the radiation and probably can add light to that.
Sure.
So, do you have any gross blood in the urine that you can see?
No.
Okay. So the two most likely things are either a urinary tract infection or irritation of the prostate from the radiation. That tends to go away by 3 months for almost everybody. You said you're on a alprazosin. Is it?
Yes, that's it.
Some people are on that. Some do tamsulosin, and that may help I was 2.5 years out. Because you can also get late symptoms. And I had some microscopic blood in the urine and urgency. And had one episode, luckily only one episode of leakage, but in a very embarrassing situation. But I went on Trental and vitamin E
No.
and for 2 weeks, and that seemed to reduce the side effects. So if that continues for a week or so, or the burning gets worse, get a urinary urinalysis, and then see the doc and let them know. But that's not unusual early on, and it usually goes away. Again, 2 to 3 years out, it can happen again, and that can be more troubling. Um, but again, that can be treated as well.
Okay,
Uh,
that's helpful information. Then the second item is not quite uh, prostate related. So excuse me, Rick. Is that when I started treatment,
Hold
I
on
came
one second.
oh,
Hold on one second on your second item because Greg has his hand up.
okay.
We just want to check if Greg has something to say on this particular topic. Did you have something to say on this issue?
Thanks, Rick. And I'll be coming up on a year out. The 1st of November with the SBRT, and Mark kind of explained it really well in terms of what my experience has been. Very similar. I'm still on tamsulosin 1 a day, and did have the irritation that Rich speaks to, as well as the decreased flow and stop-start that had lasted beyond the 90 days. So at this point, unless there's a UTI going on, I really wouldn't worry about it. Things will subside in due time. It's all due to the radiation doing its job, irritating the tissues and kind of clamping down on the urethra for voiding. So
Okay,
thanks.
I
one
appreciate
thing
that. Thank you. That was helpful. And
One thing I would recommend is that there are also travel kits that allow you to be in your car, and it's like a big
oh yeah,
funnel that screws on to
that's right.
an empty Coke bottle, just kind of as an emergency thing. And I wish that I had kept some spare clothes in the back of the car, because I showed up at a political rally and didn't realize it was going to take about an hour to check in.
Oh my God.
And that was a very uncomfortable hour. So
Okay.
plan your travels around the possibility that you may have to go sooner than you think.
Okay. And the second thing I was going to ask is that right when I started treatment, I came down with COVID. So there was no turning back. Once the treatment started, they stuck with it and gowned up, blah blah blah. But anyone had COVID in 3 months out still get tired? I mean, I feel like around 2 or 3 o'clock in the afternoon, I feel like I've been drugged. I can't get the energy back. It's just I don't know if that's a symptom of long-term COVID or what. But man, I just have to slow down and stop at that time of day in the afternoon.
Are you on ADT?
No.
Okay. Yeah, unfortunately, that there are all kinds of things that people experience. And in terms of, is there a test for long-term COVID? No, there aren't. But people can become insulin-dependent diabetics. You can lose taste for a period of time. You can have fatigue. Um, I've heard all kinds of things suggested as potential ways to treat it. And I think the best thing, if you're concerned about that and it gets where you have a difficult time managing your day-to-day existence, one of the university programs nearby will likely have a long COVID clinic where they can address it, and at least they're on top of the literature.
Okay, that's a good tip. Thank you. Okay,
Yeah.
thank you very much. I'm good.
Daryl, are we able to hear you now?
I don't know. Are you?
Yes.
Hey,
All
there
right.
you are. I heard you talking 3+4. I'm 3+4, diagnosed back in April, and immediately the urologist wanted to take it out. I backed off, and I've talked to radiation, and I'm actually scheduled for SBRT next week. I just found this group.
Fantastic. During the radiation, do they have you on any medicine for bladder or Cialis?
I don't know yet. I'm on a Cialis daily right now, so I'll probably continue that as I go. But I'm scheduled for my OAR. Let's see, when is it? September 6th.
So, Daryl, can you just take us through your disease demographics? Because one thing that we find in this group, we've been doing it a long time, and as we explained to Paul at the beginning, I don't think you were here yet, is a lot of people get treated when they don't necessarily need to be treated.
I've
And
kind of
so,
wondered that.
yes, so we'd like to know. Why don't I let Dr. Mark, because he does such a great job, take you through. He has a few questions that will help us. Go ahead, Dr. Mark.
Oh, I need to go get my white coat on. I have my airport shirt for Andrew. We didn't go in the swimming pool with like the other dogs.
You did. Could you show us? Could you please show everybody your logo on that airport shirt? Because I always love to see it.
Well, here's the front one. I don't know.
Yes.
That one or the one on the back?
Well, that one will do. That it says waggage claim, by the way, with a W, waggage claim. Would you just like forgive us, Daryl, but since we're now recording this and since we have a star amongst us,
Okay. So I can show.
we'd like you to know a little bit about Andrew. This is Andrew, and if you come to PCRI, the word is that you might even get to meet Andrew in person. But just tell us a little bit about waggage claim and what it does.
Yeah. Rick suggested that he give a talk at this convention, and if nothing else, that I may have to interview him. Waggage claim is at Burbank Airport. If you do come in for the seminar, you want to fly to LAX, but Burbank is much more pleasant, easier to get in and out of. And he and I walk down the halls and look for people who look like they need to pet a dog. And it's my wife's favorite time of the week, 2 hours without a husband or a dog. So we do that. And then we also go to a couple of senior homes visiting there. And tomorrow we're going to a university that's getting there started for the season. And it's kept me out of trouble, as has this as well. So, Daryl, first of all, how old are you?
I'm 55.
Okay, and where do you live?
I live in Roosevelt, Utah.
Okay, and do you have any other relatives who've had prostate cancer?
None that I know of.
Okay, and how did you get diagnosed? What got you to the doc, and what did they do?
Well, about a year ago, my general practitioner started testing. Well, he asked me if I had urine problems at night, and I said, yeah, I get up during the night. He says, well, let's do a PSA. I came in at like 4, and then he says, well, let's test it here in a few more months. We tested again, and it went up to, I think it was 4.13 or something like that. And they said, well, you're still real close to the 4, which is kind of their line. And so we waited 3 more months, and we tested again, and I think it was 3.98. He says, well, you've come down. Let's do it again. Maybe we'll talk about seeing a urologist. And I live in a small town. We don't trust our doctors. So I'm like, I'm going to go see a urologist. So I went to the city and got an appointment. And he did the finger. He didn't feel nothing. He's like, well, a 4, you should be, that's too high for a 55-year-old is what he told me.
Yes.
So he said, let's get an MRI. We scheduled MRI. And we found one small spot, 0.42 inches, and with the MRI. And then we did the biopsy right after that. And they found 3 positive cores, uh, three
How
three
many
plus.
did they do?
They did 12. And I swore he said he did 13. He was going to take an extra one right by the sample, or right by the area, or next to it. But he said he only took, the test came back and there was only 12. But anyway, so I had 3 of 12, 3 plus 4. The one was 50%, one was 2 or 20%. And then we sent it off for Decipher, and that came back at 0.52. But the urologist, he immediately went to surgery, and I'm like, I'm not doing that. He's like, well, radiation won't even look at you. You're way too young for that. Surgery's your only option.
Well,
So
he's right. He's right in that young people do better with surgery. But, the question is, does better than who? The young person who's 55 is going to do a lot better with surgery than the 80-year-old who goes through surgery. But it also means that at 55, you could look at the next 40 years of dealing with complications from surgery, ED, and incontinence, which appear to be more likely with that. So you look at the SBRT. Do you know what kind of machine they use for doing it? Because not all SBRTs are the same.
no, I don't know exactly the brand. I don't know the brand. I just know he's going to put in gold markers and put an OAR in.
Right.
Facial.
And that's a gel that sits between the prostate and the rectum, and it raises the prostate about 1.5 centimeters away so that the dose to the rectal wall is reduced, and hopefully there are less rectal symptoms
Yes.
as a result of doing that. The Cialis is good for a couple of reasons. One, it helps maintain blood flow to the tissue as you're going through this. But there's also some interesting studies lately that show that Cialis may reduce cardiovascular risk about 40%. So on the one hand, we can say, darn, we have to take Cialis because we're treating cancer. And on the other hand, we can say, well, at least we cut the risk of cardiovascular disease. When do you start?
Well, I talked with a radiologist. At first, we were talking about high dose brachytherapy, and I read a bunch of things about SBRT that were better, and so I decided to do that instead. But
Is your radiation oncologist someone who is a generalist, where in the morning they're going to radiate breast disease and then brain tumors, and then in the afternoon do prostate?
no,
Or is it someone who mostly is GU disease?
he's mostly the prostate.
I mean, it sounds like you're in a pretty good shape and you've got things well decided. Do you have any specific questions for the rest of us? And then I'll let.
I don't know. I
Ho-
always hear
Hold on a
surveillance.
minute. Let me just interrupt a second, Daryl.
Yeah.
Again, I want to come back to what I heard you say is you've got 3 positive cores. Is that right?
Yes. Yes.
And are they all 3 plus 4?
I don't know that. I need to dive in better.
Okay, so we need to know if 1, 2, or all 3 are 3 plus 4. You also mentioned to me 0.4 something inches, which is unusual because normally everything's measured in centimeters.
Yeah. They gave it in, I think, millimeters, and so I converted it
Right.
to inches because I know inches.
I got it. But 0.4 inches would be about a centimeter.
A centimeter. Yeah.
Yeah. 0.4 inches is roughly around a centimeter, very roughly.
Yeah. They gave it to me in millimeters. I don't remember the millimeters though.
Okay. So what we want to do first of all is just make sure that you in fact are not a candidate. You may want to get treated, but if you're a candidate for active surveillance and about 20% of men with in your situation choose active surveillance, maybe more would if they were given the option, because a lot of people aren't even given the option. You may be able to sit on your disease, which is the discussion we had with Paul earlier on and a couple of the other guys. Now, if you go to a local urologist in a community practice or a local radiation oncologist, they're not going to encourage you to do that because they don't make any money off of you. I mean, I hate to be so callous, but that is generally the case. And so before you dive in to do this and you get the seeds and you get everything else, we really want to ascertain that you need treatment. Because once you get the treatment, there's no return. And if you got side effects from the treatment, as Jim will tell you momentarily, because he's got his hand up, I see it, you can't turn that around. And what we're really concerned, like in Paul's situation, he doesn't have a lot of cancer. It's only in one place, and people are talking to him about radiation. People are talking to him about surgery. It's not necessary. In my own particular case, because this sort of makes sense, I was 56 when I was diagnosed, so I was at the same age that you were. Unfortunately, my disease was pretty serious. It was locally advanced, and I was a 4 plus 4, so I didn't have any choice. I could have done the surgery, or I could have done radiation. I chose to do the radiation for certain reasons that really aren't pertinent to the discussion with you. But you are a decent candidate for radiation. Would people prefer to do surgery for you? Yes, because in younger men, they like to do surgery because we get in and can see things and younger men can tolerate it. But there's nothing wrong. Any doctor, any urologist who says you're not a candidate for surgery, I hightail it out of that office and find another urologist away, which is exactly what you did.
Yes.
You said radiation. You're not a candidate for radiation. That's what you meant.
Yes, sorry. Any urologist who says you're not a candidate for radiation, just get out of that office because he's got his white shoes on and he's selling you. But really what we need to know, and before you do anything else, we need to know how much cancer you have in there, and you need to understand it, and we can help you understand it. At that point, then let's talk about, are you a good candidate for treatment? Maybe you're not. And there's going to be docs at Huntsman there are going to be urologists at Huntsman who will supervise you on active surveillance. I can't remember the names, but I know they've got a couple of good people for active surveillance. And you go to Huntsman, they get paid the same whether they treat you or they don't treat you. So that's why we tend to send people to centers of excellence. I also know that there's a very good guy at it's a I'll have to give you the name in a second, but it's a large practice, and he's an oncologist there. But I do trust him, and I could get a name from him from somebody who wouldn't immediately want to treat you. It's Intermountain. Does that sound like a
Yeah.
cancer? Intermountain, right? So we have some good relationships at Intermountain. I could get a name for you at Intermountain.
Rick,
Of somebody who would favor active surveillance. But I'm just concerned you're getting treated when you don't really need to get treated. Jim, that's the point to hand over to you. That's your cue.
All right. I was going to say that as well, but the first thing you have to do is you've got to get a real firm grip on your Gleason score and what those slides are telling you. And I think this is a case that just cries out for a second reading of the slides. You need to get those slides reviewed in a center of excellence like Johns Hopkins or something like that, because that is going to tell you exactly what your disease state is, and it's going to drive every decision you make, whether it's active surveillance or radical treatment. You're a young guy. I was 58 when I had surgery. And, at that time, now 14 years ago, active surveillance was just coming into being. But having that surgery was the worst decision I ever made in my life. And you've got a good long time to live with the consequences of whatever decision you make. And if you can maintain on active surveillance for a period of time, treatments are improving all the time. I think, and we've seen that a lot in radiation. Despite what they tell you about robots and single ports and all the other bullshit they throw around, I don't think there's been much improvement in surgery, at least not in the outcomes. But it sounds like you've kind of figured that out about surgery. But you need to get a second read on those slides and really get your arms around what that's telling you about your condition. And
Daryl, Daryl, you said 50%. Was that 50% for or 50% of the core? And then another was the other two positive cores were 20% for?
Ooh, I don't know.
Oh, I thought you had
I'm
said.
all new to this.
So do you have the path report in front of you?
I don't have it in front of me. They never
Oh,
even gave it to me. I'm just going by what they
Oh my
told me.
gosh.
okay.
Oh my
Then
gosh.
you definitely need that, and
yeah.
you need to send it off to Hopkins, or there's a fellow in New York City, Dr. Ming Zhao, who's at Mount Sinai until he moves to NYU. And what's great about sending it to him is he'll get on the phone and really explain. He trained with Dr. Epstein, who was at Hopkins, and he'll get on the phone and explain to you exactly what the pathology means and the significance. I thought I heard you say 50, 20, and 20, which if it was that grade of 4 with the intermediate, I might be more concerned. But if it's not sent off to a center that really is a center of excellence
Well,
in reading prostate slides, you don't know what you
you
have.
know, I would say something more. If you don't even have, Daryl, if you don't even have your report, that gives me some concern.
Amen.
I mean, you've got to have your report, man. I mean, first of all, if you're 3+4, which it sounds like you are, worst case, you've got plenty of time. So I would put everything on hold right now. Keep coming back to us. We'll help you understand the report. That's what we do here. And we'll navigate you to somebody who's not going to have a horse in this race. or if they do, they may be a urologist, they may be a radiation oncologist, but they're not going to care whether you get treated or you don't get treated, and they're going to give you unbiased advice. You said to me up in Roosevelt, Utah, you don't trust doctors. Well, this is why you don't trust doctors.
Yeah.
Now, we at AnCan, we know a lot of doctors around the country, and we send our folks to people that we trust, and we trust them because they've treated other people who have been in here, and we've seen how they treat. And in your case, that's really what I'd like to do. And I'll reach out to my guy, Dr. Dan at Intermountain after the meeting, and I'll try and get some names, or at least a name of a urologist close to Roosevelt, in case you don't want to go to Huntsman.
Okay. I do know a urologist. I do know a urologist here in town, and he just moved in. But maybe I'll go visit with him.
Well, no, you see, the problem is that you've got to know if that urologist favors watching active surveillance, because otherwise they'll give you they'll sell you a whole bill of goods about why you're not a candidate for active surveillance. Now, they might have reason. You're a younger guy, and that's one reason that why. But at the same time, if you don't have a lot of cancer, we got time. It ain't gonna go anywhere. It ain't gonna kill you, and you may be a decent candidate to watch this disease. The other thing is that you could finish up with the new guy in town who's going to tell you, well, you got to get surgery.
Yeah. Which
you don't. So don't just waste your money going to another guy. Do you have good insurance?
Yes, but Intermountain doesn't take it.
Oh, Intermountain does not take it. Okay.
No. It's Blue Cross Blue Shield.
Okay. Does Huntsman take it?
I'm pretty sure they do.
Yeah.
Okay, so we'll find your name at Huntsman. How far is Roosevelt from Salt Lake City?
It's like 150 miles. We go there all the time. We have family.
Okay. So let's try and find your name at Huntsman. There are a couple of urologists there who I do believe are part of some active surveillance programs. And let's get, and if they come out and say, no, you got to get treated, then we can talk to you about the best way to get treated. I mean, you might be a good candidate for seeds, which is the low dose. Let me tell you, in my own case, I got seeds and I also got radiation because my disease was more progressed. But the seeds are a really easy process. And for a lot of people with not much cancer, do you know how big your prostate is? Has anybody ever told you that?
No.
Okay, so without knowing the size of your prostate, all these doctors telling you 4 is too high, 4 is too low, it's meaningless. Because if you've got a small prostate, 4 could be very high. If you've got a big prostate, and maybe that's what was giving you issues peeing at night, 4 could be low. And and this is why it drives me nuts when they tell you, they give you advice based on 4. I tell you what I do here. I hear you were pretty stable over a few years, over 18 months. That's great. It means that the cancer's not going anywhere. And it also tells me you could be a good candidate for active surveillance. If your PSA had gone from 4 to 8 over that period, we'd be really worried, but it didn't. And if you've got a 40 cc prostate, which is pretty normal, then 4 is a perfect number for you. And that's not an indicator. Now, something's going on there, but we don't exactly know what. We got to get those slides reread. We got to get you to a urologist who would be willing to consider watching your disease, and then we'll decide. But don't plunge in. Don't get those fiduciaries planted next week and start with the treatment just yet. I can't give you medical advice, but I can tell you that we don't think you have enough information to make that decision, and nobody's even taken you through your biopsy report, which
Yeah.
is
Yeah,
very
that's
disappointing.
very concerning.
Okay. I'm
You
on
know,
a. My doctor gave me his personal number. I text him all the time. Maybe I'll text him and see if I can get that.
yeah, see if they can email it to you, and then join us in the active surveillance group on Wednesday of this week, and we can help you walk through that pathology report and help you sort it out. If you can get them to email it to you or something like that.
Okay.
Yeah, and we'll be the first ones to say, yeah, you got to get treatment, man. We've said it to enough people. But we're also going to be the first ones to say, if you don't want to get radiation or surgery, then treatment in the form of active surveillance might be appropriate for you.
Yeah. You know, in any event, a second opinion here is really, really important. A second opinion from somebody in a center of excellence who's independent, you owe that to yourself.
Yeah,
Okay.
to you, not just to yourself, to your family and to your wife, because this is life changing. Even if you do the radiation, it can be life changing.
Yes.
Okay. Now, Paul and Daryl, please send me your emails so we put you in the we put you in the database, not so we can come back and ask you for money all the time, like certain other organizations. We put you in the database because we send out reminders before every group and or between two groups. So if we get you in the database, you'll get a reminder the day before that there's a meeting coming up. So, and if you don't want to put it in for everybody, just send it to me, rd@ancan.org, and I'll get you in the database. And then we have some other meetings. Daryl, are you a vet?
Am I? No.
You're not. And Paul, are you a vet?
No, I'm not.
Okay, because we have meetings for vets. We've got some mental health meeting. We've got all kinds of different stuff going on here. But our goal is to make this journey as easy as we can for you, and to make sure that people who get treated are people who need to be treated. And need to be treated might mean you want to be treated. That's fine. But if you don't want to be treated with surgery, we'll help you figure out how to get the active surveillance right.
Thank you.
That's all the
Oh,
people
by
I
the
have.
way, sorry, can I just say you can sign up yourself too. You don't have to send me your email. If you go to ancan.org, I'll put it in the chat window. I know you're on the phone, so it's hard to see stuff in the chat window. But
I'm pretty sure I get all your emails and your advance notices, so I think
you
I'm good
do?
there. Yeah, that's how I
Oh,
got this.
okay. Well, I'll put ancan.org in the chat window, and you can sign up yourself in there as well.
Okay.
So that's all I have on my list. Does anybody have anything they want to share, or any jokes that they might want to share with me? I mean, in light
No,
of Wednesday being a comedy night and a cancer comedy night, if we can't come up with anything for prostate cancer, I think we'll be left behind. I mean, we got to do as well as those colon cancer people.
you better get
Where's
Mason.
Mason? I was going to say, where's Mason?
Where's Mason when you need him? Mark,
Absolutely.
Dr. Mark, you better call Mason in. There was somebody else who had some bad jokes as well. Recently, I can't think who it was that had bad jokes.
Howie.
Howie.
Yeah, Howie.
That's it. I will say to you, I just want to reiterate what Dr. Mark said. The PCRI conference is really awesome. Especially if you're in a decision-making mode. Um, the doctors who are going to be there are outstanding. The opportunity to talk to other people, to be around several hundred other prostate cancer patients. I mean, you can walk around, you can talk to the people that make these radiation machines, who make space ore, who make all the different drugs, and it's very worthwhile. We will have a table, so we'll be there in person.
And Andrew
Um,
will be there.
Andrew will be there, which we're very excited about. Yeah, we'd like to see Andrew up on the main stage. I don't know if that will happen or not, but
He just wanted to know, he said he's a male dog and he hadn't had his PSA checked. He wanted to make sure no one was going to do a prostate exam. He wanted me to guarantee that before he agreed to come.
okay. Let me just mention to everybody that we are talking to Andrew, but he's being a bit of a primo dono about possibly appearing on our Solo Arts Heel in short order. His manager is very tough. I just want to tell you, he's got a hell of an agent there. But we are hoping that he will be on Solo Arts Heel. He has some fans. He does have a fan in Michigan City. But who says that he could never do what Andrew does. Isn't that right, Jim? Gary's not a candidate for this.
No, I don't. It's not in his DNA.
It's not in his DNA. But anyway, but just seriously, PCRI is really worthwhile. Think about it, and we're having a dinner at a local Greek restaurant on the Friday night, which will be nice for all of us AnCanners to get together. So we're looking forward to doing that. So, and the other thing is, if you didn't read the reminder, if anybody didn't read the reminder, make sure you do, because we're featuring Colonel Boykin in this week's reminder. I had the distinct pleasure of hosting Colonel Boykin last week, and we actually made a dash into Mexico, but the power was out, so we had to come back, right, Colonel Boykin?
That's right. We did cross the line, and we drove as deep as we could in the dark.
we walked across. Mrs. Jordan was very impressed, as was the Colonel, as to how easy it was to walk across. And then when we found the restaurant closed, we walked right back. And we did that all in a space of about 5 to 10 minutes, which was still allowed us to get dinner on the US side. But the Colonel's coming back, and we plan to go over again. Oh, Jim, Jim Schrate and I and his wife and Jane and others, we did the same thing, but the power was on when we did it, right, Jim? And it was a good restaurant, right?
It was a good restaurant. Very good.
Nah, definitely coming back.
You're all welcome.
Okay, well, we'll look forward to seeing you guys. Actually, it'll be after PCRI.
Ooh.
I would guess the second.
Yeah.
It'll be right after PCRI for the next meeting. So hope to meet people there. And the last one they did, they had the USC Trojan Marching Band welcome us as we walked into the hall. There's bound to be surprises and special guests whenever Mark Moyad is involved. He puts on a show. So
Yep.
thank you. We'll see you next time.
Yeah, and Paul
Okay.
and Daryl, please come on Wednesday night, same time, same place.
I'd love to. Can I just ask one thing? Can I get some clarification on my my actual biopsy too? I mean, because I still, I know we went through it, but there's just a lot of questions I have because I mean I do have it, but nobody ever went over it with me. So
Why don't you
We
make a
can
list?
do that.
Right. Yeah. Make a list of the questions, and as Jim says, they'll get answered on Wednesday. I usually see in that meeting, but I usually come in a bit later. But Jim will be there. There'll be other people there, and if you make a list and have a list in front of you, I'm sure we can help you, Paul.
okay. And one other thing, how do I find? Because I've searched for it for centers of excellence, as you guys have mentioned.
Ah,
I mean, I've Googled that and everything pops up. Everybody's a
okay.
center of excellence.
So hold on a minute. You're in the chat window, right? Here's
Uh,
here's what here's what I'll do for you. I'm
okay.
gonna put in two links, and they will name the centers of excellence. Just bear with me 1 second whilst
Okay.
I pull them up. NCI Cancer Centers. So the first one is going to be the NCI Cancer Centers, which is the National Cancer Institute Centers, which I'm pretty certain includes Emory. Does it not, Mark? They're an NCI, aren't they?
And they're
Yes.
NCI. But again, I would not. I don't
I
feel
think they're
Right.
comfortable with it. I
really,
think you'd do better at Moffitt or Vanderbilt or Neal Shore in that
Yep.
area.
So there's the NCI, and then the other one is NCCN, which is the National Comprehensive Cancer Center Network, and I'll just get that for you right now. NCCN. Whoa, I know why. NCCN. Where are my centers? NCCN, palliative care, reimbursement, members. Okay. NCCN Network Members Institution. Paste. And Daryl, thank you for your email. I'll make sure that you're in. Paul, did you send us your email, or would
I
you
haven't
rather
been in
not?
there. No, I don't mind at all. The more help I can
Okay.
get, the better.
Okay, well, open the chat and you've got links to the NCI Center and you've got links to the NCCN centers.
Oh, I have all kinds of stuff in here. Fantastic.
Yep,
Mm-hmm.
yeah.
Awesome.
Now, if you want to make sure you have a copy when it finishes, those three little dots at the top will allow you to download what's in the chat window. You click on those
Okay.
three vertical dots, and it will give you the option to download. Okay.
Okay. Super.
And come on in on Monday. But if we don't have your email, you won't get the reminder for
Oh,
Wednesday. But you'll know where it is. You know where it
just
is.
send you my email or my full name, or you have that. I don't know.
Don't have your full name, and we don't have your email, so you can
Okay.
either put it in the chat window right now, or send it to me at rd@ancan.org.
I don't have a problem. Like I said, I know you all are in the same boat, so I can use all the help I can get.
Right. And we're here to give you all the help you can get as well. So
I appreciate it. I just came across this by accident today and saw somebody had mentioned it, and I'm glad I did.
how did you find us? I'm just curious. We're just curious.
It was from one of these forum groups that I've Zero, I believe it
Okay.
is. Somebody had
Yeah,
mentioned it.
probably. Yeah, probably zeros forum groups is would make sense.
But one of the
Definitely.
participants on there, he just put a link on there and mentioned that this was going on tonight. So
Yeah,
without that, I wouldn't have been here. So it's a good thing.
Glad
Great.
to hear that.
Yeah.
Appreciate it.
yeah, yeah.
And
We,
now Wednesday, that's at 8. Did you say 8 o'clock or 7 o'clock our time?
the same time as this meeting, whatever time
Okay.
for you, it's at exactly the same time.
Awesome.
Okay, and in this room. So, and yes, Daryl, you're on there, but I'll make sure you're on for all the meetings. And Paul, I'll take care of you right now. Thank you very much.
Thank you.
All right, gents.
We'll see you all later. Hope to meet some of you in person at PCRI.
Yes, so does Andrew. Goodbye.
All right.
Thank
Thank you.
you.
Bye.
Bye. Thank you.
Well,